The thing we normally order the most is a CAC scan. That's coronary arterial calcium score. We get a value to tie in. Mostly it's the people that are on statins or ezetimibe for cholesterol, and we want to get a value. Can you maybe take us through? I mean, that is a CT scan.
Yeah.
So just for our listeners again, you would get to SCP, book in, and they'll take you to a CT scanner, which is like a donut that you lie in, and they take you through in and out. But it's quite quick.
Yeah, well, the nice thing about a calcium score is it's completely non-invasive. You don't need an IV. There's no injection, and with the so the discomfort and maybe the small risk that comes with that. And it's a quick exam. The exam itself, the scan, takes 10 seconds perhaps. The preamble and getting you set up and lying down and putting up ECG leads, because we gate the heart just to get it as still an image as possible. But it's completely painless and uneventful. And radiation dose is, I think, about 2 to 3 millisieverts. So that's about 1 year of just walking around, and the benefit that you get from that information, that certainly greatly outweighs the risks.
Yeah. So you grade the calcium that's in the artery walls to guide a score. You use an algorithm to get a score for us.
Yeah, so that score was set up, I think, in the 80s, called the Agatston score, and that there's a linear relationship between the amount of calcium and the cardiovascular risk. The more calcium you have, the more risk you have. And so a calcium score is a good way of risk stratifying, but also following up treatment to see whether you're going in the right direction. So that is also often a study that you'd repeat.
Yeah, we like the study for our asymptomatic patients, slightly, in the 55, slightly younger patients that we just want to guide in the treatment. We've got some resistance against taking a statin or one of the other cholesterol-lowering drugs to get a score done. But the 0 score doesn't mean that you don't have plaque formation.
Yeah.
It means that you don't have calcifications in the plaque.
Yeah, so I mean, seeing the plaque often is a wake-up call for the patient, and he realizes, okay, things have happened, and that's exactly what it means. Something has happened in the past, and the plaque is probably already stabilized, but it is calcified and it's harder. It's less likely to cause problems, but that just means there is other plaque that hasn't stabilized yet. And certainly, if you have no plaque, if a patient has chest pain and no plaque, he might still be at great risk, because the plaque just hasn't calcified yet, and could still narrow the lumen. So if a patient is symptomatic and he's got chest pain that could be cardiac, certainly you wouldn't stop at just a calcium score.
Absolutely. And I think the statistic says around about 10% of the CAC scans that's got a 0 score might have still has plaque formation, and about 15% of those, they might have severe occlusion actually without seeing it on a CAC scan. But still, it's an excellent screening test for us.
Yeah.